Because, they keep the track who did what. I don't have the names, but they told us, okay, so this one, what they tell Rajiv, inbox, Rajiv, what is from Rajiv? Forward, this one, forward, right? Forward. Paste. We till didn't finish the ECG PowerPoints. My goodness.
Yeah, that's why I'm confused, because is it not happening Wednesday or not?
Who is that? Yusra?
Hi, it's Huda, yeah.
This is the Yusra?
No, Huda.
Or Huda?
Yeah.
So anyway, we have to be ready for the exam on Wednesday. But
Yeah.
today I'm going to talk to Vera because it has to be on campus. It has to be the computer lab free, okay? So I am going to, in between, when I start the class, and then in between I'm going to send an email and then see the response, and then we are going to decide whether it's going to be Wednesday or Thursday. If it is
that's
Thursday,
all right.
till now, I have to work on that, dear sweetie. Okay, so I am going to work on that because, and then I am going to work for your finals, midterms, not finals. Okay.
All right, thank you.
Okay. Oh, dear. Except the Christiana, I sent everyone's LLSP final marks, right? Everybody get it. Christiana, probably I didn't able to do it because it's the last moment is completed. Did everyone got it?
Didn't check yet, ma'am.
In your personal email, I did it last week, not today.
Yes, ma'am. Is it in our student
I received
portal?
mine.
Yes, miss. Got it.
Got it. Okay. Yeah, just make sure if anyone doesn't got it, then I have to again go to D12 SEM because you guys didn't. You told me you guys cannot see your final marks, right?
Yes. I'll check it now, ma'am. Thank you.
Yeah. I know only Christiana is last moment, so I didn't able to complete it.
We shouldn't really worry about final marks or anything like that until after everything is done. So our ECG test and our midterms. Don't panic. Breathe. Everything's going to be there. It's all good.
Yeah, right. That's right, Kara.
It looks like Kara.
Say it again, Tara.
No. It looks like Kara has the link to see everyone's marks.
I need to hear that. Kara, I need to hear that again. Go for it.
I think everybody did pass, and majority of you did good things. At the beginning, there are a couple of discrepancies. Somebody is out, somebody is sick, this, that. But, you guys can pay attention. You can give time. You guys are doing good. Whoever is getting a little bit late mark or at the bottom mark, whenever they get time to study, immediately they jump up. I understand when they cannot get the time to study. But once answer has given in the D12, I am totally handicapped. I cannot do anything except your professionalism, which is also recorded, and some marks, the assignment and these things. Till everything is recorded, but till I can give little bit. Where I'm giving 0.5 marks, if I see one word is telling with me. So yeah, but sometimes if you guys really did it, in general, you guys did good. I'm good. But you guys getting forgetting. That's the problem, What is happening if I ask you the questions from the anatomy? That's why I told, yeah. That's why I'm telling you for a long time. Every time, just chart at least whenever you get time, even for the day, I am okay. Day review, I am going to do half an hour or 1 hour, 15 minutes previous. That's why I used to do. Otherwise, I am going to fail too, because it's not possible to remember from the ethics to the ECG, everything, all the reviews, all the questions.
Yes, that's true, ma'am.
It's not
That's true,
possible. So,
Miss.
yeah. So every day I used to do when I was a student, but whenever throughout my life, whenever I did the daily things. I put a lot of efforts
Yeah.
up to I spent 1 hour, 45 minutes for that one. 1 or 2 days is happen is very difficult, so maybe it takes. But every day I take 15 minutes, even 10 questions, 15 questions. I'm going to do the review. So that's why I can be updated. Otherwise, if you ask me some things from the deep anatomy, I will not be able to answer every time, because that time you have to do the partial. For us, every time you are going back and forward, question and answer. Till if you suddenly ask me, I cannot answer, to be honest with you. But because I don't have to do the exam, so I don't do the reviews nowadays. But when I was a student, I used to do that because I have to pass, which may not need it in my profession, but I have to pass.
Right.
Because I know how students were feeling it very tough to do all the reviews at the end. And when you're going to the final, there will be more modules, more chapters are going to be included, right? I'll appreciate it. Mhm. So, yeah, so this one I need to flag. Okay, now I have to go to D12 again. This one. This one, ECG, that review has been done, right? I have test one final. Okay, so that one is done. No, we have to. D12. PowerPoints. Okay, D12 PowerPoints. Mm-hmm. I had sent you some extra PowerPoints from my previous one for the ECG also, right?
Yes, miss.
I did it, right? Okay, good.
Yes.
From my, not from the D12, which is my own PowerPoint. I give it to you guys, right?
Yes.
Okay. Okay, so close. Okay, so hide this one. The student. Okay, so this one.
Miss, are you talking about the PowerPoint for the ECG or was that something else?
ECG. Only
ECG,
this is for the whole class. ECG probably I sent some from mine, previous one.
No, I don't
Okay,
guess. I don't think so. It was only from D to L, right?
No.
Oh, those
D12.
for the blood flow?
So listen,
Which one?
The blood
listen,
flow.
listen to me one thing. From the D12, the PowerPoint, everything you have, right? I don't have to send you anything new because all you can see it. If I send it anything, that is from another platform when I used to teach in another platform. From there, I have some own reviews on notes or PowerPoint, so which I made it for my students. Probably I sent some of them. What are the blood flow and what I send it, you guys? What is this one? Some important notes. I send you this one. Some important notes on ECG. Did I send you that one too?
No, the only one you sent, it was the review from D2L.
Heck. This is confusing me.
You sent the blood flow through the heart, and then
Yes.
you sent the electrocardiogram ECG.
Yeah, that's why I just tried to. Which one I send you?
I got that. I got that.
Yeah, we have that.
That's why I'm just checking. Okay, so that's why. That was helpful for you guys or no?
Yes.
Yes, ma'am. Definitely.
Yeah,
Yes,
yes,
miss.
ma'am. It's helpful.
So let me close this one. Probably I did this one too, but just and I send you the ECG, your assignment answer sheet also, right? With the
Yes,
answer?
ma'am.
Okay, ECG.
The assessment.
Yes, we have that.
Yes, okay.
Yeah.
Before this, before ECG things, let me update whatever I send you and whatever not. Okay, so D12 ECG detail reviews. So I send you this one with the answer, right? Okay, so I can move this one here to here. So that one is done. Go there. Move to okay. So important notes probably I send it, but let me just send it again in case. I think I send it, but new email. Probably you have that one. I told you about the headings, UD and this and that. That was okay. But till let me send it in case I cannot go through this one, this one, this one. So copy, paste. Everybody is getting an email now. No more problem, right? For the Yahoo or this and that.
Yeah, yes, ma'am. We can receive now.
Oh, there is no problem, right? Anymore? Okay. Okay.
Yes, ma'am. No more problem.
Okay. Probably you received this one already, but just in case. And this one. Okay, so you will get another email. Okay, so this one is, what is this one? Copy. Link copied, close. Okay. New. I don't know this one. Okay. Huh. Why this some important notes, vitals we have to learn. Okay, so this is for G final. You have to do final also now. Vital assessment. Okay. So and then is first to 10. This is the final reviews first to 10. So just let me sure. This is there. Okay. I already, this is the duplicate. It become duplicate. Okay. So whatever is there. Okay, so it's going to be duplicate though. but it's okay. So I can just close that one. Did well. Refuse. This one. Delete. Delete is going to be too much complicated now. Okay. So, okay. Final. Copy link. Okay. My mail. Okay. Rest. What I did and what is coming. Put in others. Copy. Paste. You guys got that email too. I forwarded to you, right? Okay, so this one.
Yes, ma'am.
Yes, ma'am. Got
Okay,
it.
okay, okay.
Actually, yeah, you have given that in campus. The special consideration.
Oh, yeah. I have to give it to on campus for sure.
Yeah, thank you.
Yeah. That is from our director, so I have to send it to. So this one. Okay, so this one, this one, paste. So then this one, okay. Need to do link copy link. Paste. Yeah. Two. Test one. So RD. So so this one have to do the bold. Okay. Yes. This one, and this one. This. Okay, so. I am just having call from the office. I'll be with you within 10 minutes, okay? Okay, just work on that,
Okay,
whatever
ma'am.
you have. Okay, okay.
Yeah.
Okay,
Thank
Miss,
you.
thank you.
Hello. Hi, can anyone open the note email, some important notes on ECG, please?
Yeah.
I couldn't open it, the first email.
Oh.
So,
There's some important notes on ECG.
yes.
Oh, that was last week. You were not. How are you, Yang Hong?
Last week. No,
yeah, I'm not sure if you have it.
No, Miss just sent the email. Miss just sent.
Oh yeah,
No,
she sent the email.
She sent two emails to us.
Yes, Young Hong, I couldn't open that one too. I think I'm gonna
Same.
ask her.
Yeah.
Oh,
Yeah, me
I couldn't
too. Something went wrong.
Yeah.
something
Technical
went wrong.
issue.
Yeah, there's an
technical
issue.
Okay. Yeah, same as me.
Yeah. We'll ask her when she comes back. It's not just you.
Right.
Okay. Okay. Thank you. Thank you,
No
Krista. Thank you,
problem.
guys.
Have you received it? ECG finals. Thank you, Miss Moon.
Yes, Rena. I can open that. Yeah. Final review, right?
Yeah.
She already sent it to us.
Thank you, Miss Moon Moon.
Yeah.
Thank you, Miss Moon Moon. We're so happy.
and also the final midterm, right? She will.
Yeah, she will also pick some questions in random. Like
Right.
70% will come out from the midterm exam. That's what she said.
Now.
70 to 80%.
Right.
Okay. Right.
Now,
Yeah.
now let's edit and answer.
Yep.
Finally.
Thank you, guys.
No problem.
Is Miss Moon Moon back?
No,
not
not
yet,
yet.
Rugyato. She's on phone call.
Jim, no. Hello?
Hello, ma'am.
Hi, ma'am.
Yes, so you're back now? Okay.
Yeah.
We have to do the D12 now.
Ma'am, we received the final review for the ECG. Thank you so much for sending that one for us.
Yes,
But did
ma'am.
you
Thank
but,
you.
but did you see the
Thank you, ma'am.
condition?
Yeah.
Essay, yes.
So be careful, okay? So if I
Yeah.
don't, then I'm
Yes,
not going
ma'am.
to work on the midterm. So everybody has to get that one then. Okay,
Yes, ma'am. Thank you.
yes,
Ma'am,
sure.
I'm back.
Oh, you're done? What the doctor told you?
Oh, I already have it for when I did my medical for the school. So they
Yeah.
said it's cover for 10 years.
Yeah, tetanus only. That's why I ask you whether you took the tetanus or not. And what they told for your wound.
Yeah, just from Whitford. It's covered 10 years. So
Okay, good. That's why I thought probably you have the tetanus. But anyway, good, you went and checked. And they said wound is okay?
yeah.
Okay, good. Let us see where we are standing for the ECG and heart rate to learn from not the heart rate, ECG and heart. Okay, so okay, we are going to which unit we are going to start. Into my heart circle. Holter is done, review done, ECG atypical patients 7-8. There are 2 units today. Okay, so what is this one? PowerPoint, what is this? It's an electrical retrieved. Educational subcommittee. Attachment, what is the attachment for them? Okay, where is that one? This one. What is this one? This one chapter 3, I don't know, 6. It is 6 overview, we did that one. 6 in healthcare readings and this and done, kind of healthcare password power. Yes, Canada healthcare person unit PowerPoint. Review that Canada health. Question not this one. Back. Okay. What is mine? One, I don't know, 1, 2, 3, 4, 5, 6, 6, a typical patient. This one. Okay. At the screen, share, and share. So you already learn about the ECG, how to do the ECG, what are the different forms of ECG, what that means, each form, how to record, how to, read ECG, what are the basic main areas which can tell you about the arteria or your ventricle. So today we are going to learn a little bit about different types of atypical patients, which are not the regular patients. So what are the different problems, how to do the ECG on those patients, okay? ECG techniques for atypical patients. There are a couple of different types of whatever we learn a little bit about the who had the head surgery or who cannot sit on the supine positions, lie on the supine positions. There are a couple of factors for different patients have, so that we'll try to learn as much as possible, and we can apply our knowledge and technique if we have faced those type of students. So these are your different, in your PowerPoint, you can see these are the different things. They give you the reference, so you can go through this one, read it. If you get get time, for sure. Okay, so, and what is this one? Slide flare. This is another video. So this is also chapter 3 for lead training. What is this one? Let me
Chapter
check.
3 for 12 lead training per course. Ontario-based hospital group.
Oh, it's 30 minutes.
Education Subcommittee.
You guys can lead this.
2008.
We already
Time
did
is not
one, but it's a 30 minutes. I don't like to spend that time. You guys can, if you let us see what is there.
So,
Let me just go.
introduction and the mechanically opens artery. Delays in out-of-hospital transport -5%. Delays in in-hospital evaluation and treatment 25 to 30.
If you guys want, you can, go through it whenever you want. It's always good to, watch videos like this. You may get some new insights, new informations, but it's not going to be your daily things. So learning objectives is our how we adapt the ECG procedures for atypical patients, like the amputee patients, pediatric patients, and also dexocardia patients. Anybody knows what dexocardia means? Okay, we are going to learn it, okay? So what are the different types of patient we told? The amputee or cast, who unfortunately have to ampute any of the limb, or they have some fractures, so they have the cast. How we are going to do the ECG for them? Dexocardia. Dextro means we can understand a little bit, is in the heart is not in the position where it should be. How the heart is inside our body, which side is which side, apex is which side, and base is which side. Hmm? Apex is faced which side of in the body?
Left side, ma'am.
Left side.
Towards the left, yeah.
Yes, and base?
The base may be on the right. I don't know.
Yes.
The right side.
You guys have to remember this is the very basic. We are starting from the anatomy till to the end of the ECG. We repeated so many times. Okay, these questions may come anytime. This is a very basic question. What is heart's apex and base is located? Which direction? If you doesn't know the normal direction, how you are going to know when there is the abnormal position of the heart? Okay? So dexocardia, the position of the heart is not in the same position. The base is the right side towards the facing towards the shoulder a little bit, and apex is towards the diaphragm on the left side. So heart is little bit more towards the left side, and also is just sitting above, almost apex is towards facing a little bit in angle towards the diaphragm on the left side. Patients unable to lay in a recumbent position. What is the where we are going to do the ECG when the patient has to be lie down on the bed. So they have some problem some back problem, bone problem, some fracture, or too much pain, or some wound, or something like that. So they cannot lie down in the supine position. So then we are going to do. It's not like that we cannot do the ECG. The patient came from some heart problem. Doctors want the ECG to say, check how their heart is, but we have to find it out and we have to do it properly so that ECG can be done properly. It can give you the result, accurate result. Burn patient, that is very difficult. Burn patient, generally we always need to have, if they comes with the image, generally other the burn patients goes to their individual department and the individual designated nurse or the professional does their ECG or any take care, because they are very sensitive, right, for the any kind of infection. But in case it comes to the emergency and we have no choice, then you have to do it, because the emergency is the first site for anything. Pediatrics, infants or the babies, too elderly, and who has the Parkinson's disease, that means who tremors a lot. So if we go to the first amputee patient, if the participant has an amputated limb, place the electrode close to the body part closest to the limb. That is the key answer for everything. Any body part, any limb, any amputated limb, if it is amputated anywhere, if it is amputated here, can you see the arrow here? My arrow, you can see the arrow. Can you see the arrow? Moving the mouse. Can you see the arrow or no? Hello?
Yes,
Yes,
ma'am.
miss.
Okay.
Yes,
Yes.
miss.
Okay, okay. So if you say that if the patient is amputated here, you can place the lead electrode here or here. But if you place the electrode here, that is always advised for R in CG, just place the corresponding electrode the other side. That is our training there, but I don't know how the D12 said. So if there is any right leg amputation is going to the up to knee, you can put it here. If it is more than that, you can put it here. So wherever that is the answer closest to that limb. Okay, body part closest to the limb. If the participant has an amputated limb, any limb, is not the leg or hand or anything, right arm, left arm, anything may happen to anyone for any reason, amputated limb, place the electrode, not the lead. You have to record the lead activity through the electrode. Now those are clear, right? So where you are going to place the electrode, and the signal is coming from the electrode using the different limbs. So that's why you have the 12 leads, electrode on the body parts closest to the limb. Okay. Amputated arms, place the electrode near shoulders. What I already told. You can put it here, you can put it here, or you can put it here in the upper clavicle bone. This is the clavicle area. So upper clavicular bone you can put where there is a no, that is muscle, no bone. Okay. Amputated legs, place the electrodes above the hip. You can put it here. So you can see they are showing you here. Here is more amputated. You can put it here and here. If it is a leg is amputated up to here, so you can put it here, or also lower abdomen. Nowadays, if we just doesn't like to keep the dress down to the waist. Place the other electrode at the same level. Whatever we trained is the same thing I told you. Place the electrode at the same level on the opposite whole limb. So you have, okay, right hand amputated. So I can place one lead here, but the left hand is okay. So I'm going to put as per the rule, I can put it here. No. Then you cannot get the parallel and good ECG. You have to get the tracing or the signal from the same position. So if there is any problem in the amputation, so if you have any problem in where is, if the hand is amputated, you can put the hand. If the leg is amputated, you can put in the hip. In case there is problem, one hand, one leg, that also happen due to, or there will be tremendous paralysis, the whole right side or left side, or the lower portion, or the hand, you never know. So then you have to place the electrodes as per the patient's condition so that you get the best result. So for any amputee leave, the answer question is going to come. Question is to place the electrode on the body part closest to the limb. Say for example, there is a amputation here. You can put here in the thigh muscle. Here they are putting. If one somehow is amputation here, so you cannot put here, you can put here. So that is you are going to, you as a technician with your knowledge, you are going to take the decision where you are going to put the electrodes for getting the best signal and best results. But always remember, where you are putting the one lead, the corresponding lead should be in the same position in the other side or in the other limb or any other side. Clear now? Document the document the change electrode position on the patient record. So you can, when you have, this is the documenting chart in case there is any review or the doctor says why there is a little bit this or that, but always you have to write it down, like the patient is ambulatory or patient is amputated in the left leg. So you, doctors know that you have placed the lead in a working area where you can get the signal, but not exactly the in the reference book. Okay, generally there is no problem happens when if you put the electrodes from here to here to here, until and unless you put the electrodes in proper place in proper way and check all the connections and activity and grounding away ECG machine, all the other disturbing material. So it's okay. So now we just know about the amputated legs. Now let's the dexocardia. What is dexocardia means? It's the malposition or disposition of the heart. That's why I ask you how the heart is located. So generally, where the heart is located in the right side of the chest rather than the left. In our heart, it is mostly staying in the left side. Major portion is staying in the left side, right? That's why you put most of the chest list electrodes on the left side, V1 to V6. Am I right?
Yes.
Yes, ma'am.
Yes, miss.
Okay, so everything you can visualize it, what I'm telling you. So as our heart is mostly is base is obviously in the right side, some part. Otherwise, that's where you are going to put the B1 chest lid. But is in general is because why? Can you tell why the heart is little bit more leftish? Anatomical position wise?
Because I think it because of the lungs, ma'am.
Both side you have the lungs.
Position. Yeah, the position is
Is it your
Obviously,
liver?
there is a part of the lungs,
bigger on the bigger
yeah,
on the right.
yeah, we have the liver also.
Oh yes, ma'am, that's right.
Liver, lungs is more spongy tissue, but liver is little bit more solid tissue. And the right liver is little bit bigger than the left.
Yes, that's correct, ma'am.
So you can understand why the anatomy is important to understand these things. If you know that, then you will not forget why the heart is towards the left side, more oriented towards the left. It's covering right and left, but more major portion of the heart is the left side. Because it needs the space in our body, it has to accommodate all the organs. They cannot press each other. They need their position in a comfortable way. So that's why. But sometimes from genetic problem, generally it comes from the genetic or hereditary. What happened? The heart is not exactly positions in the normal position. So what happened? It generally shifted to the right side of the chest rather than the left. So dexocardia is the most common form of cardiac malposition. It's not a disease. That's why it said the malposition. Sorry, common form of malposition refers to where the heart is located in the right side of the chest rather than the left. So you are putting all the electrodes and other things and getting the signal. Do you think you are going to get the exact ECG recording if the heart is in the dextrocardia?
No, ma'am, I don't think
No,
so.
because you are not going to get the proper POFs, QRS complex, because your chest lead you are putting it in the left side, and left side that is the heart is just opposite. So what you are going to get? You are going to negative POFs and QRS of complex, because no positive deflection will be there in lead 1. If the heart is not there, what you are going to get? Are you going to get any positive deflection? No, right? Is that understandable?
Yes, ma'am.
For everyone, not only for Evelyn?
Yes, ma'am.
Yeah, because we are just dealing with the ECG right now. Okay, so this is called the dextrocardia. Dextro means anything just opposite side. So dextro and heart is related to cardia. Is everybody? I just hear from Louis and I just hear from Evelyn. Did everybody understand these questions may come?
Yes,
See,
ma'am.
that's
Not
why
for
I get
here.
worried, man, because I
Yes.
answer the questions and I don't ever get acknowledged. So I feel like I'm not going to get any participation or just lose marks in that area because I do
No,
answer.
no, I know, Kara, you do. I know.
Okay.
Whenever I hear everyone, I know who doesn't participate at all and who does. You can understand from there when I picking up by names, those people doesn't understand. Sorry to say that. But for whom I understand, I hear, sometimes I doesn't, sometimes I stop them. No, not you, not you. Because participation from the whole class, not only specifically Kara or Evelyn or Huda or Yusra or Amina or anything. Sometimes I have to stop Amina, sometimes I have to stop you, sometimes I have to stop Evelyn. I'm just giving a couple of examples. Yes, but I need the participation from everyone. So it's not like that you doesn't understand that. If you cannot understand, tell me right now. Who has a mm, mm, that I'm coming later. I am just like to ask you whether everybody understand why the dexocardia means. Everyone, I want to know from everyone what is dexocardia means. Did everyone understand
Yes,
regarding the
Myocardium.
heart
ma'am.
Yes, we do.
position? Regarding the
Yes,
heart
Pericardium,
yes.
yes,
circumference,
regarding
Yes,
the heart
ma'am.
position, apex,
aortic
base. Okay,
surface.
now, if everybody understand, now I want to know if the dexocardia of the heart, which side of the apex of the heart for the dexocardia patient?
Is located on the right side.
Right side of
The
the
right
heart.
side of the
Right.
chest.
Yes.
Right side of the right side of the chest, but apex is going to be located in the right side. Which direction?
The right side.
Mm-hmm. Is going to be the shoulder or is going to be towards the diaphragm? You have to give the exact answer to me.
Towards chest.
The
Towards the
chest, ma'am.
chest, diaphragm.
The apex
Towards
is
the
on the right
diaphragm.
side.
Yeah.
Yes, thank you. So you have to just put the heart how it was, just revert it as a mirror image. So it's just reverting that side. So now the apex of the heart is going to be on the right side facing towards the diaphragm. Clear? Can you visualize the heart in that position?
Yes, ma'am.
And then
Yes.
what is going to be the base? Basis of the heart in the dextrocardia Patient, where is the base of the heart facing?
It will be on the left side.
On the
Left
The
side,
left
facing
side.
facing towards up or down or shoulder?
Shoulder, ma'am.
shoulder.
Okay. Everybody agrees?
Yes, miss.
Yes, ma'am.
Yes.
Okay. Okay.
Yes.
Yes. Yes. Who called miss? Is anyone didn't understand? Any confusion?
No, ma'am. Understand.
Okay. Okay.
Ma'am, so that means dextrocardia is a total change in the position of the heart, like it turned upside down.
Not upside down. Sidewise. It turned sidewise. Upside down
Just the
means
side.
upside down means your base will be down facing towards the diaphragm and
Okay.
apex is going to be towards the shoulder. No, it's not upside down. It's from
Just the
left,
two sides changed
yeah, left
opposite.
to right. Yeah, just
Okay.
took the heart from one side, placing the other side.
Okay. I
Instead of right
understand.
side, sending the left side, from the left side to right side. Our heart
Okay,
is mainly
like
by
you're
birth.
looking at the heart from a mirror backwards. Like you're looking at the heart from a mirror, like the
Exactly,
what's it called?
exactly.
Like a
That's
Reflection.
mirror
yeah,
image.
Reflection.
Yeah.
that's Louis
Yeah.
told.
Yes.
Yeah, that's Louis told. So same thing.
Yeah.
It's kind of mirror image. Yeah, that is the
Okay.
malposition. Because what's called malposition, that's the normal one, right? So that is called the
Yes.
malposition. Good. I need this type of joining so that we can understand. Everybody understand that. Till I didn't hear everyone. I can now. I guys know everyone's voice. Whose voice is coming? Whose voice is off? Okay. So when the dextrocardia, obviously the heart is positioning in the other side. So then you are not going to get all the POFs, QRX complex, right? Because it cannot get the signal because heart is the other side. From where the signal will come? Because the electrical activity is going on the other side of the heart. Instead of left, it's going to the right side. Right? Everyone?
Yes,
Understand?
ma'am.
Yes, ma'am.
Yes,
Understand.
ma'am.
Yes, ma'am.
Yes, ma'am.
Okay. Okay, good. So then whatever the main generally we doesn't see is a negative P wave. So these questions come why I'm telling you so many times. Dextrocardia may be suspected by they are going to give you negative POS, positive QRS complex, negative POS, negative QRS complex, positive POS, negative QRX complex. So they can give you different combinations, multiple choice. So it's going to be negative POFs and negative QRX complex in lead 1. Okay.
Okay. Okay, ma'am.
So
Thanks.
what can the MLA to do in this situation? What you are going to do? A second ECG should be recorded with a chest lead from V3 to V6, position on the right side because it's in the right side now.
Yeah.
Understand? What V1 and V2 position is going to be same is going to record, but from V3 is mainly from the place in the other side, normal side. So from the V3 to V6 is going to be just opposite the electrodes.
So whatever that was on the
Position is
left,
going to be, location is going to be the same.
Mm-hmm.
Only it should be instead of the left side, it is going to the right side.
Right side.
yeah.
But only V3 from V3 to
No,
V6.
So
yeah,
here,
V1
okay,
and V2
okay,
remains.
okay. So
V1
V1,
and
yeah,
V,
V1
okay.
and V2, V1 and V2 we do for normal heart, right?
Mm-hmm.
Is placed
Yeah.
just fourth intercostal area. You have to remember the fourth intercostal area right beside the sternum within 1 inch, right?
Yes, ma'am.
Yes.
So V1 in this case we are placing in the right and V2 we are placing in the same place in the left side.
Okay.
Yes.
Am I telling the right things or wrong things?
Yes, miss.
Yes, miss, it's
Right?
right.
Okay, because I am getting confused now. So yeah, so you all
No,
agree with
V1
it.
is in V1
There's
is
a
in the
picture.
right, on the right,
Yeah, yeah,
and
that's
then
what I'm telling.
V2 is on
V2
the
is
left.
on the
So
left
those,
side, fourth intercostal area. Okay, so these two
okay.
electrodes, shh, these two electrodes are going to be placed in the same position where there is a dextrocardia or a normal.
Got it.
Because these two are in for all any position is same, because heart is on the V1 is going to act as a V2 and V2 is going to act as a V1, but the electrodes are there. But then the main is hardly then changes from left to right side. So for the placement of V3 to V6, so where we are going to place the V4 now? What is going to the position? Anyone wants to volunteer except Amina, Evelyn, Kara, Huda, no, Yusra, except couple of them. Anyone and to answer? I want to hear what is going to be the V4 for the
The B4 is in
dextrocardia.
the
Yeah, Varna. Yes,
It will
Varna.
be, okay, sorry.
in the
Okay.
right now.
Right where? What is going to position?
In the middle of the clavicle down to the fourth intercostal.
No, fourth intercostal.
In the
There's a
middle.
fifth intercostal.
Fifth intercostal.
Fifth
Fifth
intercostal.
intercostal.
Space.
Is that
one.
everybody?
Fifth one.
Did everybody do your ECG that way in front of you? You just draw a
Yes,
heart
ma'am.
and do that.
In
Are
the
you
fifth
placing
one.
Are you placing in the dextrocardia patient that V4 in the right side of the heart, mid clavicular line, and fifth intercostal area?
Fifth intercostal.
Everybody putting
Yeah.
take a
Yes.
paper and pen and place your electrode there in the dextrocardia position.
Yeah,
Miss,
yes, ma'am.
Miss, I have a question.
Yes.
Yeah, so for dextrocardiac patient, we should do two ECGs. One is like the place the electrodes like the normal patient. So we got the negative P wave and negative QRS complex. As the opposite, it's opposite.
Okay. Thank you for the question. I appreciate that. Okay. So first, if any patient come, you doesn't know anything of the patient, no history, previous history for anything or ECG, then you have to, so then you have to first do the normal ECG as you do. Okay.
Oh, yes.
So when in the normal ECG, you are not getting the proper ECG waves, what you should go, especially the P wave and QRX complex, you are getting the negative waves. So basically that time you have to do another ECG considering that whether the patient has the dextrocardia position.
Oh, okay, that's the second ECG.
Second, but sometimes if the patient has the history or the patient knows, sometimes the patient, which patients they knows. First time the patient doesn't know, nobody knows about the heart, because generally we don't do the ECG every time, right? Until and unless there is some problem in the heart, then the doctor order the ECG. The first time ECG, always we do the normal ECG.
Yeah.
Then if we feel or see the discrepancies on the P wave and QRS, whatever should be positive, it's coming in the negative, no results. So then we try to do another ECG to make sure whether the patient heart is not in the dextrocardia position.
Okay, yeah, right. That's my question. Yeah.
Okay.
Thank you so
Dextrocardia
much.
position. But sometimes some patients who already did the ECG before for any reason, they knows they have the dextrocardia heart. Sometimes they tell us,
yes,
our heart is my heart is dextrocardia position, or the family member can, oh, he has a dextrocardia heart. So if you know that one, you can go for the dextrocardia ECG.
Just,
Or if it is charted in the history or anything in your the patient history, previous history, so then you can go for the dextrocardia.
Yeah, so can we do just the second ECG, like we know the patient is dextrocardiac patient?
If you know already the patient is dextrocardia, so if the patient tells you I am dextrocardia, okay, or the patient family told you that he is dextrocardia, or from your requisition or your chart or your note there is a dextrocardia patient.
From
doctor or from the previous history of the patient. When it comes, it's written near the patient history, right? Where the patient comes for what? Sometimes, especially in the hospital, it has, or the doctor's note, they are going to write down dextrocardia patient. So if you saw the note, the dextrocardia patient, are you going to do the normal ECG? No. Then you have to do the ECG as per rule of the dextrocardia is the opposite.
Okay, got it.
All
Thank you.
Okay, everybody clears that one? That's a good question,
Yes.
Ningong. I appreciate that. Everybody, okay, Asnet, please.
I have a question. So let me understand this, please. So a descocardia patient, right? How did that happen? Did they born like that, or
It's mainly hereditary.
Oh, okay. All right. Thanks. Got it.
Mainly hereditary. Until unless for any reason, I don't know that sophisticated level in case they have to replace the heart in the other side or something, but it's mainly hereditary.
Okay. Thank you.
Okay. Thanks. Ask question that I like it. Even sometimes I don't explain those things because I know. So it happens that it didn't come to my mind that I have to tell this one. Ask question. That is very good.
Ma'am, I have
But
a question. So
yes.
is dextrocardia is a life-threatening or
No,
not?
no, no, not at all. Not at all. Not at all.
Oh,
Not at all.
I
If there
see.
is no problem in your heart valve, if there is no problem in your heart muscle, if there is no problem in the clot or anything, heart is functioning well. No problem. Only its
Okay.
position. Yes. Dextrocardia. Yes. Yeah. So there is no life-threatening problem, but the dextrocardia patient may have also developed some heart problem, right? Any normal patient, anyone. So if there is a problem in heart, their septum, their valve, their what is called the pacemaker, AV node, SA node, any blockage in the artery, any muscle weakness, anything, that is going to be show in the ECG for the dextrocardia patient, but dextrocardia patient has nothing to do. They are doing fine. Only
Okay,
as a MLT, when you are doing the ECG, if you know the patient is dextrocardia, or in your normal ECG you are not getting you are getting the negative P or QRS wave, so then you have to do a dextrocardiac ECG.
So Miss, question again, please.
Yes.
So for the descocardia patient, would it be like more of a strain for them on the right side than the
No.
left of a normal? No.
No. You have the heart on the left side. Do you feel strain?
No, but that's weird now. But that's a normal for a normal person.
No. They are developed in that. So they have no problem. The heart needs the space to be positioned in one place so that they can function. All the electrical connection, all the veins, everything is going to be the same. So it's not a problem for them.
Okay.
Okay. So only
Yes,
as a MLT, what you have to do, you have to do the dextrocardia ECG. And what is the rule? You have to place the V3 to V6 just in the opposite side, on the right side. Okay.
Okay.
So that
Yes,
is
I
the
have a
say
question.
using the same using the same intercostal spacing. What I just told you as the example for the V4 is the mid clavicle area, fifth intercostal space, and in the right side. So it's going to be the same. What is going to position of a V3? Again, Christiana, V3. Dextrocardia, where you are going to put the V3 electrode?
The V3, so it's going to be on the right side of the midway between the V2 and V4.
Very good, very good, very good. I like that. Okay, now who is going to Huda? What is going to be the V6? Huda, are you there? Huda, you doesn't respond.
I can answer, Mom.
You can't answer?
I can
Okay.
answer.
Who is that?
Mary's.
Okay, Mary, still.
For the V6 for dextrocardia patient,
Yes.
it's in the 5th intercostal. On the instead of left, it's in the right mid axillary.
Mid axillary. Very good, very good. Mid axillary. Yes, mid axillary. Good, very good. Okay, now we left the which one? V5. Who likes to volunteer for the V5?
Me, miss.
Okay, go ahead. Go ahead.
So V5, it would be on the 5th intercostal space at the left anterior.
What? The fifth intercostal, I understand. Then what? What side?
The left anterior, I can't call it. Miss, I can't call it. Anterior. Anterior
auxiliary.
Axillary line. Axillary line. Sorry. So it's on the 5th intercasual space.
Causal law. SNF, be with me. Okay? Try. I really appreciate that you are trying. Is not in causal place. Intercostal. No, just no. Inter, one by one. Costal.
So
costal. These are all medical. This is all medical terminology. There's nothing to shy, nothing to. Everybody takes time. At the beginning, it takes time for me also. But if you doesn't start pronouncing in the right way, it's going to be always problem. One or two time you do it properly, is going to come. Intercostal.
Intercostal space.
Yes.
Left artillery.
Not left. There is nothing is now there. The heart is in the dextrocardia position.
On the right.
Oh, you're talking about with the dextro. Okay, so now it's going to be.
We are discussing the dextrocardia.
Okay. So it's going to be on the right. Anterior.
Anterior. You know the interior. You can very nicely pronounce your interior decoration. Why you cannot say anterior? If you can spell interior, it should be an in instead of in. Interior decoration, you know. Then tell anterior. Anti means front. Anterior axillary.
Okay, that's where it is. Yes, miss. Thank you.
Okay.
So far,
I didn't hear anything from Savannah. I have to see. We have to have. Okay. Huda said that cannot understand the Kara already participated. Fazado, Chris. They are always say Salen, Rugiato, Jenaida. You have to tell me. Okay. Next time, what I'm going to do, I'm going to give you the PowerPoint and tell each one of you to describe and teach in the class, and I'm going to be a student. That's I have to do. So everybody can teach me. That is going to be the best thing.
Ma'am, can I have a question again? Oh, sorry.
No. So can you raise your? I cannot. I am in the another page. Who is that? Hello. Who is that? Because I'm in another page. And you can ask me the question. Who is that?
It's Ying Hong. It's Ying Hong, ma'am.
Okay. Because I am on your PowerPoint page. Yes, tell me. I have to go back there now. Then
yeah, Miss. A question about for the chest electrodes, we place the opposite position.
Yeah, that's we
from
discussed.
V1
Yeah.
to V6. Yeah.
No,
And
V3 to V6. V1 and V2 is going to be the same position.
So V1 is also on the right or the left?
What it was? What it was at the beginning? For the normal ECG, you was on the right side.
V1
right
we
side,
place the right side. But for the dextrose cardiac patient, we place V1 the right or left.
It's going to be the V1 and V2 can be same. Okay, so say same intercostal spacing and anatomic landmarks for that one.
So V1 is the
V1
right
and V2 should remain in the usual position because these are the two position only. The same, the right and left, they are in the same position for both sides. What is the normal heart or dextrocardia heart? That area is same. V1 and V2 electrodes will be same.
Okay. And another question is about the standard limb lids.
There will be no problem. There will be no problem. It can be same position.
All the same. Okay.
Yeah.
Okay. Thank you so much, ma'am.
Okay. So see the image now.
Miss, I have another question.
Yes.
How common is dextrocardia in patients? Like, will we encounter it often? Or...
It depends upon the. We rarely get dextrocardia position. I don't have the ratio to be honest with you. I can search and tell you. Okay, later.
Okay.
So yeah. Okay. Yeah. Because it depends upon country to country, place to place. Is rare. Okay. So now we can see the position. So V1, V2. Okay. Can you see it? Now, before you used to put in this side, right? Now it has been changed to this side on the right side. So before mid clavicular line, first is clavicle, mid clavicle line, and in the fourth intercostal, fifth intercostal, on this one, the fifth intercostal area. Then you are putting the V3. So that's why now telling they are on right. So that's why they designated this V3R. In generally, we can V1, V2, V3, V4, V5, V6, right? So to make sure, they just telling the V2 and V1 is the same position. Only now this one used to call to V2 when you are pushed the left side, right? This was V1, this was V2. Now electrodes placement will be the same. Now the name has been changed to V1 right to V2R. All others are same, only in the right side in their perspective position. Is that clear now for the dextrocardia patient?
Yes,
Yes,
clear.
miss.
I have a question.
It's clear.
Yes.
For the augmented leads, will it also change the position? Like the white leads will be on the other side?
Augmented lead doesn't change position. How you are going to place the electrode, they are going to looking in the same way. The Ethiopian triangle, instead of this side, right to left, is going to be recorded in is going to be totally opposite. But it's going to record in the same way. Same way, only from the other direction. Is that clear?
Okay, ma'am.
Ethiopian triangle is going to be same, right? Only the position is going to be the different because you are having the limb leads. Ethiopian triangle is mainly connected with the limb leads. Is that right?
Yes.
Yes.
Yes, miss.
Yes, ma'am.
Okay. Okay. So ECG features of dextrocardia is right axis deviation. It has the positive QRX complex with upright P and T waves. It was not anymore negative in AVR. Lead 1 inversion of all complexes is going to be inverted P wave, negative QRS, inverted. What is the lead 1 characteristics? Only everything is going to the opposite direction. Absent of R wave progression in the chest lead, dominant S waves. So this one also sometimes come questions. The absent of R wave progression in the chest lead is the couple of things. Positive QRS and positive deflection for the in the AVR, okay, because it's now showing in the is going for the augmented lead from the right side. It is looking the you guys know, I don't have to repeat it, so it's going to be it's already 11. So basically you have to remember QRX complex and P and T waves. When you are doing the ECG, placing all the electrodes in the other side is now going to give you the upright P and T waves. There is a absence of R wave progression, QRS. So QR is R wave progression in the chest lead. Dominant S waves throughout. Okay, so this is kind of dextrocardia patient. So sometimes accidental lead reversal, specifically reversal of the left and right arm electrodes, may produce similar pictures to the dextrocardia in the limb leads, but with normal appearance of the pre. So for the normal ECG, in case if you put the right arm lead to the left arm, limb leads, if you just opposite it in the normal patient, it can give you the dextrocardia effect in the limb leads. The normal patient who has the left side oriented heart, right? You are placing the leaves in standard leaves. Right arm should be right arm and left arm should be left arm. By mistake, you didn't look that. You put the right arm lead to the left arm and left arm lead to the right arm. Sometimes it gives you the reversal ECG. Now, patients who cannot lie down. Dextrocardia chapter is over now. Patient who cannot lie down. Patient may be in wheelchair, be pregnant, or have a back injury or burns. Attach electrodes as usual. There is no problem in attaching all positions will be same. But place a book under the feet to eliminate the electrical interference, either book or any paper or anything. If the feet is on the wheelchair metal, you know the wheelchair, the footrest is the metal, right?
Yes, ma'am.
So either you have to take out the feet and put it in the ground, or you have to put some, it said book, we generally don't put the book, some napkins or anything, or some bed sheet or anything, we just put it there and tell the patient to rest on that, so that there will be no effect from the metal. That's why they said eliminate electrical interference. Attach electrodes as usual, but place a book under the feet. We generally put the book under the feet. Generally, we put the either bed sheet or any foam pad or anything to eliminate electrical interference. What is the rating in red? Sometimes they ask you the patient who cannot lie down, or you are doing the ECG when the patient is sitting condition who cannot lie down. So they can give you what you have to do. All others are same. There is no problem. Only also you can see the patient here. I can see the patient hand should not touch this side rail, the handrail. No electrical things.
Interference.
So you have to tell the patient to put the hands inside so that it doesn't touch the metal. Okay. And also the feet, you have to put some barrier. Already I told you, break contact with metal arms rest and or bed rails by using a towel or sheet over the metal. You put the bed sheet. When you are doing the ECG, who are in the, the side rails has to be there for any condition. Patient may fall or anything happens. So generally, the patient, if the patient doesn't touch anything, the metal or anything, there is no problem. The patient is totally lying on the bed or sitting on the chair, not touching anything is fine. In case the patient touch, so we have to pay for something which is non-conductive, either paper or bed sheet or towel, so that the patient body cannot get touched with the metal. And make a notation on the patient's ECG record. So we did the ECG in the sitting condition like that. Female patient consideration. V1 and V2 may be placed higher due to implants or large breast. That I was telling you on that day. So sometimes it's so if the huge implant or huge large base, sometimes V1 and V2 have to be placed. It should be intercostal, fourth intercostal, but due to push of the heavy breast, everything has been pushed up. So in generally where you are feeling the fourth intercostal area should be, it is little bit higher. So V1 and V2 may be placed higher due to implants or large breast. Place electrodes under breast, make note on the chart. Women who have had mastectomy may have fragile skin. Be careful placing and removing the electrodes because they have the, when you are putting the electrodes and when you are taking out, be careful. After the mastectomy, something the skins are fragile, and so do for the elderly people and so do for the kids. When you are putting the electrodes and bringing out, don't like that you are taking it. Take it slowly because the skins are fragile. If there is a mastectomy, take a note. So burn patient, that is the most hardest one. Selection of ECG electrodes should be done consulting with the nurse or the doctor. If there is a, it's very difficult, to be honest with you, we rarely do the burn patient. Rarely do. If there is a burn in the chest, generally we cannot do the ECG. They have to do some other way. If the burn is the back or something, you can still do the front side ECG, but the patient cannot lie down, so it has to be in the wheelchair or sitting condition or as per the nurse or doctor said. So burn patient selection of ECG electrodes, where you are going to put the electrodes, should be done consulting with the nurse. Skin is extremely sensitive even on the non-burned areas because they are pain receptors are too sensitive now due to the burn. Even on the other areas you are going to touch or something is going to be more painful or sensitive. The skin is extremely sensitive even on the non-burned areas. Place disposable electrodes on any available spot on the limb. If you see where you can see there is no burn spot or anything, so you are going to push for the electrode leads. Severely burned patients, crop clips to skin staples into the patient esophageal lead. We don't do this one, okay? We are not allowed to do this one. This is the they saying. So you can know severe burn patient use croc clips. I never seen this one, to be honest with you, because we don't get this type of patient. We never have the emergency to do the ECG. But it said croc clips to skin staple inserted in the patient esophageal lead. So from the esophageal lead, they put these clips inside. So, and then finally they recorded the ECG. I never see in my life how to do that ECG. Only I read it, I just teach it. But this is the thing. Only you can tell that if it cannot be done. This question generally doesn't come. Burn patient, you have to say selection of ECG record should be done consulting with the nurse, and it should be placed properly where there is an available spot in the limbs. And the croc clips skin staples inserted in the patient esophageal lead. Esophageal lead, you know the esophageal. So if they are going to put through the mouth inside some cross clip leads.
Yes.
Yes.
Well, what if, say for instance, the patient have a pacemaker? How would you do that?
You have to keep the record. You have to note it down. From the pacemaker, you can see it. It's already tell that pacemaker, and you have to record it. The patient have a pacemaker.
Okay.
That's
Thanks.
all. Good. Pediatrics. Pediatrics patient, the technique adapted to meet the requirements of the child as the child is, how big, small, anything. With how to, you have to talk, you have to calm down the baby because they are so much worse and anything, they got scared. Their heart rate become high. Sometimes they move too much because they are not the adult, right? Even is the when you are taking the blood, it's only one, but when it comes to the ECG, all the worse and this and they got scared. That's why a patient and gentle approach is recommended to obtain artifact-free ECG. Talk with them something, not talking with them. Oh, this is not going to hurt you at all. You know how you place this one. Like you have a Especially when I do the vein puncture, I tell it's less than your paper card. Do you have the paper card? How it is that? Oh, it's painful. It's going to be less than that. So if you tell them like this type of things, they can understand, oh, what is the, the power or how much they can feel. So same thing. You have to tell, oh, we are going to play with something, you put something, pasting or something, we are going to put. So always talk with them, try to distract them, try to talk with them what they like, whether they like this Spider-Man or they like this or that, what movie you like, how many friends you have any brother, sister. So we just always talk like that so that they can distract. And then by this time, you have to tell them what you have to do that in a um, very gentle and very like easy way to so that you can get an artifact-free ECG. The recording method is likely that described for the adults. So, if possible, the recording should be made with the child semi-incumbent, but the sitting position may be used if this prevents restlessness or distress. Sometimes if you tell the patient, baby, to lie down, they get more distressed. They become more restless. They're scared. So if like that, supine position is always better, but if not, then you can slowly incline the bed as much as possible. Are you okay? Are you okay? So you can see mom, you can see dad. Okay, that's fine. So then you can do that so that they are not rest and not in stress. And in also in this concern, I don't know whether they are telling you later, maybe. So sometimes if the patient is too small, sometimes you have to cut the electrodes in the half because otherwise the total electrodes you cannot fit it in the total chest. If it's a 1 month baby, it's a newborn baby, be 7 days baby, if it is a 2 months baby also, and the very skinny baby, the electrodes, what's the width of the electrodes, you cannot cover them everything because each one is going to be overlap with another one, and then the signal is going to be haphazard mix noise. So you have to cut the electrodes in the half, but keep the area where you are going to tack with your lead wires. Then you have to put in the same position as you did for the adults. But generally nowadays in the ECG machine, there is option for pediatric ECG. So before doing the ECG, if you see there is an option for the pediatric ECG, you have to click on that pediatric ECG and then you are going to record the ECG with all the instructions giving in your ECG machine. So here, what I'm telling you, you can see the baby is so small, use smaller electrodes if available, keep the baby warm. So you have to wrap them. The baby is wriggling, fold a diaper or towel diagonally. Place the folded edge under the buttocks that they can feel that and over the forearm so that baby doesn't feel cold. Infants may need to use a specifier to fall asleep for an accurate ECG stressing. You can give if the sleeping is fine, otherwise you have to give the what is called the pacifier. Most of the time, you lot of patience for recording the kids ECG because they even you tell them don't move, they are not going to understand. They are not going to listen. So you have to either mom or dad or anybody, they have to keep them in very comfortable position so that or you talk in such a way they are not going to move. Mom and dad, okay, talk with your baby. Or nowadays, that is a very easy instrument, the cell phone, showing that the video. All babies are attracted to that. And sometimes even they are doing that, they are going to put your hand like this. So again, you have to do until you get this one. And it cannot take the space. You have to cut it in the half and place in there. Elderly, geriatric patients, apply electrodes carefully to avoid damaging thin skin. Note non-standard body positions on tracing if you are pulling in the not exactly the same position. Place electrodes on the back only if necessary. Only if there is some problem in the some chest or something, then we are going to tell them to place in the. That is mainly depending upon the how doctors want it. Okay. Parkinson's disease, that is another problem because they are always moving their hands without their knowledge. Sometimes the confused patients. Patients with Parkinson's disease may have an episode of shaking while attempt to record the ECG. What you are going to do, record when the tumor is minimum. Just wait and wait and wait and see when the patient is a little bit cool and there is no noise is coming out from the muscle or the traumatic tear artifact is not coming out, is a very minimum level. If the patient is still you cannot record the ECG at all because it's so advanced stage, is tremoring. So then slowly take the hands and put them under their buttock. Put hands, palm down beneath their buttocks to reduce shaking. Because you are not doing anything, they are placing their hand under their buttocks so that reduce shaking. These questions will come. But the Parkinson's disease, if that has no control when they are shaking, how you are going to do the ECG to do the minimum tremor? They will give a lot of options, but the good answer is the place there. Put their hands, palms down beneath the buttock to reduce shaking. So that's why. How this is test your knowledge, how you can determine the patient is dextrocardiac. We all know now, right? Negative PUS and negative QRS complex in lead 1. Agree? Everyone?
Yes, ma'am. Yes, ma'am.
Everyone? Okay.
Yes, ma'am.
I need the voice. I need the
Yes,
voice from
ma'am.
the okay.
Yes, ma'am.
Yes.
Everybody, so if there is dextrocardia, how you are going to understand negative POS and negative QRS complex in lead 1.
Lead one.
In lead 1. Okay? Okay. What is the most important step before you start an ECG of the patient who comes in a wheelchair?
Eliminate electrical interference, like break contact with metal from the armrest.
And also from the feet.
Or
And from the feet, yeah.
Yes.
Okay. Break contact with metal armrest, and you have the answer in your things, right? Bed rails by using a towel or sheet over the metal. Okay.
Yes.
I don't agree with this total answer because they didn't tell you. That's why you told seeing the answer. People start an ECG and the person who comes in the wheelchair. They didn't tell the metal using a towel sheet on the bed rails. What is the bed rails? Metal armrests. Bed rails are when the patient is on the bed.
Yeah.
It should not come to the wheelchair then, okay? The wheelchair most important is the metal armrest and the feet rest.
Yes.
That's the two very important area you have to break the contact.
Correct.
When the patient is on the bed, sorry, sometimes I don't agree with that. So when the patient is bed, then you have to protect from the bed rails. If the patient is touching the bed rails with that. If the patient is not touching, if the patient is lying on the bed properly, no need. But if the patient is the bed rolls holding the hand or something or somewhere, then you have to break the contact. But the wheelchair for sure you have to. Okay. How can you position a patient who presents with uncontrollable tremors like Parkinson's disease to record the best ECG? We just told. Answer, please.
Ask or help them to place their hands
Under their buttock.
under their
Under
lap.
their bum.
Yeah, or
Yes.
under their buttocks.
Palm down. Good.
Palm down.
Palm down. Yeah.
Yeah.
Let's watch an ECG on a pediatric patient and discuss the following questions. If there is any difference with position, chest lead or pediatric. Okay, you see the video.
This is Ella Rose, and today we are performing an ECG. I have already gained consent and have already entered her details into the ECG machine. So now we are going to do some skin preparation. I'm just feeling her rib spacings and doing exfoliation on those spaces.
You know, you're doing really well.
Also exfoliating her wrists, and then I will do her ankles.
And this one. And I'm just going to do your ankles as well, okay?
Girl. Now we're just going to take the ISO wipes and we're going to wipe over the areas that we exfoliated. And we're going to do your arms.
It smells like the glass is washed.
Yeah, it does, doesn't it?
They smell like a glass of water. It's so cute.
So now we're ready to place the electrodes onto Ella Rose.
Yeah, we've tried them
Yeah,
before.
tried them before. So I'm just going to feel your ribs again. The electrodes are placed on the body facing down, just feeling Ella Rose's spaces.
Can I take them off?
Yeah, when we're finished you can take them off. Yeah?
Yeah.
Good. So this one is coming where? So on the child, we place one of the electrodes over to the right side of the chest. And then one comes under your underarm. Just under here.
Just new. We don't do this on this side. Okay.
One
We
more.
cut the electrodes and do that.
Electrodes on the wrist will then be placed facing down.
Yes, ma'am.
Yeah, we just cut the electrode. They did for your son too, right? In the same
Yes,
one
ma'am.
side, like the adult
And
one. We don't do
ankles
this one.
Yeah.
facing up.
Yeah. 3 actually on the right, ma'am.
Yeah, everything on the right side.
The
Oh, really?
15 leads, I guess.
They did the 15 leads. That's a different one. For your son, it was a 15 lead. Yeah.
You're gonna be like a movie star now.
You are going to be like a movie star. Now we're going to attach the wires onto the electrodes. No. I've got the numbers on them.
Go.
Okay, so let's go. So we just attach them to the edge of the electrode, making sure the clip doesn't go too far up onto the electrode. And it comes up to 3. 4.
5, 6, 7, 8, 9, 10, 11, 12, 13, 14.
You're so good. How old are you?
6.
6? You look too little for 6. You look about 5. Just try to keep the wires straight without too many kinks in them. When is your birthday?
I forgot. August.
What number?
20th.
20th. Ooh, that's exciting.
It feels funny.
It feels funny. So Ella Rose, in a minute, I'm going to get you to lay. So now we have all the electrodes on. Yeah. We're going to instruct the patient to lay nice and still. Okay. No talking or moving for a moment.
I'm going to cover you up now, sweetie.
And we just cover her up to maintain her dignity.
And I'm going to come over here and take the picture.
When she's laying nice and still, we have a nice clear trace, nice steady heartbeat. We're going to start.
Okay. No, there's not letters inside your body.
Now we've got the trace.
Well done. Just unclip.
We unclip the wires from the electrodes. Pull the electrode off, stick them to the glove on the back of the hand.
Go. This one. Here. Just gonna fold that back. Good girl. And then we're gonna just peel them off. Ooh, that one's a little sticky, isn't it? Ow. Ouch. Lucky you're not hairy. Ouch. Ouch. Last one. Good girl. I'm going to slide them out of there. Good girl.
Okie dokie. What is there now? Medical patients. We did this one. And this one. I know, Asnet, you are going to ask me for the break.
No, miss.
Oh, really? You are not hungry today? Very good.
Good. I mean, the break is always good, but Miss, so
Okay, we are done.
for the child, for the
Yeah.
kid, I have a question. So for the kid, they have an extra electro on
No, not extra electrode. They put one of them because for the position is too many thick. So I thought I saw that one. This is the sixth one. But I think one of them they put it in the left side. Generally, we don't do that. But I will check with the ECG. Yes, generally, maybe one, it looks like V3 they position in the right side.
Yeah,
V3 one.
Yes,
It
miss.
looks like the
It would be
V3
three.
they put in the right side. Yeah, because you know
Yeah.
the electrodes, they doesn't have any space there in the chest on the right side. It's covering. So generally cut it down and put them there. That's why I showed
Okay,
you
miss.
the cut it down, yeah, so that it can hold
Thank
in the
you.
same place. Okay, go for break. Next we have to do
Thank you,
that one,
Miss.
then next one, yeah, and then we are going to, yeah, okay. It's 11:17.
Thank you.
Sorry for the, because I have to explain a little bit more about this atypical patients, especially the, okay. So go ahead. We are up to the unit 7. We'll see what the unit 7 is.
So
We are going to
what
the unit
time
7.
back?
We
Half an
see
hour?
this one, right? The ECG on a tail. Oh, so you have to do this one, activities and links. So when you come back, you can do this one. Okay, you go half an hour. Let me see what is this one.
Thank you,
Okay,
miss.
So this in, you have to do it. This is your, you are going to do it now after your break, or you can come back and do this one. Okay, so this one, the
We'll
test your
come back.
knowledge. Yeah.
We'll come when we come back. We do it, Miss.
Okay, there's another video on the, okay.
Yeah.
Okay. This one is already did. Okay, let me see. Oh, we already did
This
this
is
one,
Ella
so there is
Rose,
no.
and today we are performing an ECG. I have already gained consent.
This one we already did, so okay.
Yeah, what time back?
Half an hour.
Okay, thank you, Miss.
Yeah.
12 first. Okay. Let me go to the here. First, this one stays. Okay, so the ECG T12 ECG, it's what happened? T12 ECG ECG vitals. Okay, so now to go here, compare here. So now in the content I was unit 7, this one. Oh, here. Hello. So let us go to the unit number 7, ECG, arrhythmia and PowerPoint. Everybody was back, I guess. So we already know what is the arrhythmia means. Arrhythmia means any kind of
Irregular heartbeats.
irregular yes, irregular heartbeats. It may cause in different forms like that. If you have any, palpitation, palpitating too fast, too high, or a feeling that you are maybe skipping one heartbeat, so you may have skipped a heartbeats. If you skip couple of heartbeats, sometimes you may pass out. Okay, fluttering, pounding in the chest, like in the chest, you are feeling the pounding effect. Sometimes you are feeling dizziness, feeling lightheaded, shortness of breath. All are symptoms. Arrhythmia, all are the symptoms for doing the ECG. Chest discomfort, weakness or fatigue, feeling very tired, sometimes numbness, feeling numbness in the or tingling in the arms, sometimes some pains radiating from your chest to your arm or in the back. So any kinds of things are the symptoms of ECG, but obviously you are feeling fatigue, weakness, pounding heart, chest tightness, shortness of breath, high heart rate or low heart rate, skipping of heart rate, any kind of things is called the arrhythmias, which can lead to a heart problem, which may be the cause of the heart problem. So you already know tachycardia is increased rhythm, which is more than 100 beats per minute. Bradycardia, decreased rhythm, less than below 60 beats per minute, except for who are involved in the, like the athletes, the regular physical activities, not the bodybuilder only. Okay, supraventricular arrhythmias. Supraventricular arrhythmias is looks like supra means above. So what is that? In the atria. Arrhythmias that begins in the atria. Where you are going to see the effect if there is supra-affective arrhythmias in the ECG? Which wave?
In the P wave.
Good, good.
Yeah, P wave.
Okay. Then the ventricular arrhythmias. Ventricular means it's in the ventricle. Obviously, you are going to see in the QRX complex. Bradyarrhythmias, which is called slow heart rhythms that may be caused by disease in the heart's conduction system, such as SA mode, AV node, bundle of His. That is called the bradyarrhythmias. Bradycardia is decreased rhythm or decreased heartbeat. But bradyarrhythmias is when the heartbeat is totally slow. It's not the supraventricular, not the ventricular. There may be some conduction, electrical conduction problem. So that is the SA node, which is the natural pacemaker, or maybe there bradyarrhythmia. Don't mix up with the bradycardia. Make a note of that. Lot of people make mistakes in the bradyarrhythmia versus bradycardia. Cardia is decreased. A cardia is related to heart. Brady means less heartbeat. But bradyarrhythmia is slow heart rhythms, not the heartbeat. Rhythms mean how is coming in the ECG, the total strip, rhythm strip. Total activity of the heart is very slow. So bradyarrhythmia. And that can be caused for any of the conduction system, starting from SA node to AV node to bundle of branches, and ultimately down the road is the Purkinje fibers, anything, anywhere. Okay. So there are a couple of examples you can see in the graph. Sometimes they are going to give you these graphs and ask you to identify what kind of heart problem or arrhythmia is there. So you see the normal sinus rhythm, which I draw in the board when I was teaching you. So normal is a regular interval. P to P to P, everything is at the same time. This P to this P, what is the difference of time from this P to another? Same. QRX complex distance. Distance means the time is going to be the same. Wave is natural, look the same. That is the normal sinus rhythm, and space generally is 60 to 100 beats per minute. Arrhythmia, when there is any abnormality, all complexes normal, rhythm irregular. These are normal. P is coming, QR is coming, then ST is Q, sorry, ST segment, the TUF is coming, but that is, you can see the isoelectric line that is irregular. One is short, one is long, one is medium. So distance between the starting from the PF to another PF or between the segments is not, this area is same. This complex is same. This complex is same, but the distance between up the T wave to starting the P wave here, and you can see this is the T wave, how long is telling in the P wave. Here is not that bad, it's a medium. So heart is not pumping properly. Is getting slow, high, or missing drip, or is taking long time. So this is the example of complex arrhythmia when there is not a specific things. When it atrial fibrillation, when is a bradycardia, bradycardia means we know less heartbeat. So it's all are same. You can see the time here is taking long time and it's slow. The units are same. These are called the complex. P, Q, R, S to T. This is called the complex. All this complex nature is same, only it is taking time. This is the bradycardia. Tachycardia is opposite. Everything is same, but you see there is no space between. The heart rate are too fast. Immediately after the TOPA is coming. Immediately after the TOPA is coming. There is no gap like this one. So heart is not getting rested to get the feel properly, or is pumping too much so that it can all fillings of the blood from the different parts, ventricles. What is atrial fibrillation? It is from the atria. So atrial fibrillation means you cannot see any specific P wave. Can you see any specific P waves? There is no basical baseline isoelectric pulse because its atria is flattering always. QRS complex is forming, ventricle is okay, but there is always P wave is not. That means there is maybe problem on the SA node. Little bit, and then here the AV node is maybe taking the responsibility to take care of the ventricular function. The baseline irregular, ventricular response also irregular, ventricular response irregular, oh, it is not showing the T wave. So QRX complex is showing, but the ventricle repolarization is not going on. So you cannot see the T wave like this one. So QRX complex is there, but then there is no ST segment. There is no T wave, and before that is getting, so baseline is very irregular, only you can see the QRS, no Q wave, no P wave. And ventricular fibrillation, rapid, wide, irregular ventricular complexes, it comes like this when the ventricle fibrillated. If you see this type of nature, instead of as a MLT, your job is to immediately contact your supervisor or the doctor or your who is your boss. What are the different causes of arrhythmias? Arrhythmias may be caused by coronary artery disease, high blood pressure, changes in the heart muscle. Sometimes you have the cardiomyopathy, your muscles are inflamed or your muscles have pain. Any valve disorder, if the valves aren't functioning properly. Electrolyte imbalance in the blood, that the sodium and potassium, those are the very important electrolytes for heart, brain, sodium, potassium, the whole body. Sodium, potassium imbalance can lead to the coma, can lead to your semi-coma stage, can lead to very fainting. So whenever there is something problem, electrolytes imbalance, the first two things comes in our mind is sodium and potassium. If there is an injury from heart attack, and also during the healing process after your heart surgery, because that time after the heart surgery, heart is still recovering, right? So that is the healing process. That time you can also see the arrhythmias. How is arrhythmia diagnosed? Electrocardiogram is the most common test used to diagnose an arrhythmia. You can use the Holter monitor, you can do the stress test with the ECG, you can do the echocardiogram, cardiac catheterization, and electrophysiology study EPS. So these all can be done to diagnose arrhythmia. But first you are going to do the ECG. From there ECG, if there is something abnormal, you feel some arrhythmias, or then to find out maybe the cause or root of the arrhythmia, they can go through different type of tests. Holter monitor is to check whether how his heart is functioning, or the arrhythmia is throughout the 24 hours or 48 hours depending on the doctor prescription. When is happening the arrhythmias, whether in the resting time or all the time, or you during eating, or physical exercise, or in your some mood exchange or any other relaxation. So they can see, Holter monitor, when this arrhythmia is happening, is a constant or specific time bound or specific cause bound or incident bound. Stress test to make sure whether your heart arrhythmia is when you are really stressed, only your heart is getting arrhythmia, or drop in the heartbeat, sometimes it happens. Echocardiogram to look at all the heart valves and everything, echocardium. Cardiac catheterization to see if there is any block or anything to make sure. And electrophysiology, see all the conduction system. Myocardial infarction, what is MI? Is a common heart attack when there is a less blood flow in the heart muscle. Heart is not getting enough oxygen, heart cannot pump properly, then it started a pain. That's the myocardial infarction. MI is a commonly called as MI is called as a common heart attack, and the cause is lack of blood flow in the heart muscle, caused by many different factors, but mostly related to a blockage. The if your hemoglobin is low, your blood volume is too low. Sometimes it takes time in the valve muscle that does not go, so less blood supply can cause anything. So, but mainly it happens. The majority, if there is a blockage in any or of the major heart arteries, whether mainly it happens the coronary artery. It's in the front or back. Coronary artery, which supplies the blood to the heart. So if that is blocked, or if it's weakened or somehow damaged, so that time it can happen that your heart is getting late blood supply, and which is calling your pain is called the myocardial infarction. Okay, there is always confusion between myocardial infarction, between myocardial ischemia. Myocardial ischemia is when blood flow to the heart muscle is obstructed by partial or complete blockage of a coronary artery by buildup of plaques or arteriosclerosis. And if the plaques ruptures, this can lead to a myocardial infarction. So ischemia is going to give you the pain. Blockage of artery is going to alert you that you may have an heart attack, myocardial infarction. You are having the pain, aka myocardial ischemia. When there is it doesn't have only one day. Sometimes it happens suddenly, one blood clot, move and block the go to the coronary artery and block it. So suddenly the pain comes. But sometimes due to the development of the block, the deposition of the cholesterol or fats can block the artery. So when there is a block in the main coronary artery by a buildup of plaques or any kind of incident, so then you are going to feel the pain is calling the myocardial ischemia. But when till you are having the block, but till there is some blood is going, is giving the pain, discomfort and other things. But if the plaque ruptures, it can go and block everything. It's called the myocardial infarction, the heart attacks. People with myocardial ischemia often do not have symptoms, but when they do, most common is chest pressure or pain on the left side. Because our heart is on the left side and its coronary artery and everything is on the going mainly to the downs towards the ventricle. So it's going to be the mainly in the left side of the heart. You can see the pain or discomfort. Development of arteriosclerosis. So first artery is big, slowly you are getting the plaques, deposition of fat or anything, and then slowly is blocking the total artery, blocking. And when the plaque burst, it blocked the whole thing. Blood clot first, limiting blood flow, leading to the myocardial infarction or heart attack. When is the plaque is forming? When it's a little bit, you are not feeling anything. When it's a little bit more, maybe blood is still going, you feel some chest discomfort, little bit, tightness in the chest, maybe some a little bit pain. But when this sometimes, but till sometimes it's not give you any effects until it's ruptured, and then it's till if you rupture and there is a little bit delay, still you have the you can get pain and heart attack, but you can survive. But it's totally blocked, it's really hard. Diagnosis of acute MI is the myocardial ischemia. How you are going to do that? By ECG tracing. Then you have to do the cardiac assay in your blood. Now your blood test comes. What is your cardiac marker? Troponin. That is the when there is a damage, the troponin released. And it comes to the blood. Seeing the troponin level, you can understand there is a heart attack already, or there is a consequence, a chance, maybe there is heart attack. What happens if there is small, it's just the patient came with a rupture, with the pain. So troponin is released. Then after 2 hours, if the troponin level does show any changes or showing little bit, say 200 level, when the patient came with the chest pain, discomfort, pain, or kind of heart attack symptoms, we do the troponin, it's not normal. Even it's normal for that time, then you are doing after 2 hours. See whether there's a change if the troponin level is elevated. If they elevated, again you are doing it. So it stays for a long time. It's getting, if the heart attack is there, the troponin is going to be elevated. And you have some levels. So after that, you say, oh, patient is in acute almost going to have a heart attack. What are the symptoms? Chest pain, radiating to the back, jaw, left or right arm, shoulder area. Dyspnea, nausea, vomiting, syncope, fainting. Obviously, there is not blood is going enough oxygen. Oxygen doesn't go enough in the blood. If not circulated, then there will be shortage in the brain too. There will be imbalance of the sodium and potassium in the body, electrolyte imbalance, which can cause the syncope or fainting. Some acute MI may be silent or asymptomatic. Sometimes some ischemia that tell that is very silent. Sometimes silent heart attack is called the. It's not major, but there is a silent heart attack. Silent heart attack occurs when, but this is not going to be stopped there, right? So if you have a silent, it's going to be increased. Maybe 1 year, 2 year, 3 year, you are going to suffer for that if cannot be catch. That time, from the ECG or from other tests, they can understand. Doctors are expert of that. That there may one silent heart attack before. Or the patient doesn't feel anything. Maybe patient came from the epigastric pain. Sometimes we saw that type patient, not any heart, chest. Epigastric, what is the epigastric region?
Upper part of the stomach.
Above the stomach.
Epigastric. Sometimes if the pain is close to the heart, the epigastric, we ask for the ECG. Because that is also sometimes misleading. People think because you are feeling nausea, you are feeling vomiting, you are feeling discomfort, and then sometimes you have too much gas also. That also gives false indication. Maybe you have the gas, but you are feeling the chest pain or something like that. So that time, if you do the epigastric patient comes, you do the ECG, and you are surprised that maybe the patient is having some heart problem, which the patient didn't understand from the symptoms that it may be heart problem, but some kind of discomfort like that, which is epigastric pain. It may be due to the gas, due to the stomach problem, due to things, or it may be due to the heart also. That is the feelings of the patient. So areas of ECG to be concentrated upon the study in the events of MI. So this is the generally doctors read that, we don't read it. This is the inferior wall of the heart. This is the lateral wall of the heart. This is the anterior or septal, anterior septal, and this is the lateral. So position lateral, which leads look like lead 1, V5 and V6. If the V1, V5 and V6, V5, V6 and V1. Lead 1, sorry, lead 1. Lead 1, V5 and V6. If there is some problem, you saw some abnormality here, that means the patient may have a problem in the lateral aspect of the heart. Same thing, the inferior, who leads that? Lead 2, lead 3, you know who does lead 2 and lead 3 now. These are the standard leads and how they look at. Lead 2 looks from the right arm to the left arm, right?
Right arm to the left leg, ma'am. Left
Good,
lower.
good. And lead 3?
Lead 3 is the goal.
Left arm to
Left
left
arm,
leg.
left leg.
Left leg to left leg. And AVF is looking from the one angle from right shoulder to the
foot.
To the foot?
no.
To
It's
the
looking
heart.
from the in the
To
heart.
the
Is the heart in that
in
side.
the
Yeah,
middle.
to the heart. Yeah.
to the
Okay.
heart.
So this is the inferior. So from here reading, now you can understand from reading the image or the tracing from these areas, they can understand what type of damage of the heart has, whether it's in the lateral wall, is the inferior wall, anterior septal wall. So V1 to V4 leads the anterior. So because they are leading in the heart in the transverse plane, right? So they can do the anterior or septal area. Okay, so this is the anterior, inferior, and lateral. This is the generally, if you see any discrepancies you see, go on still. You don't have to diagnose or analyze what is the lateral or anterior or inferior. If you any tracing, abnormal tracing or alternate in the tracing, than the normal ECG, that you have to know how the normal ECG looks like. Then you have to remediate to report to, so that doctors can take care of that and they can read the ECG more details, or the cardiologist can do that and they can do their treatment policy. So ECG diagnosis, why the ST elevation of so important?
Sorry.
It is very important to diagnose for a MI already had, or their patient may has got the MI to heart attack. It's called the, you know this diagram now, PQRS. Then there is a J point where the S wave is meeting the T wave. So this is the T wave, ST. So J point at which the QRS complex meets the ST segment. This is the ST segment. What is the? This is the end of the Q wave and beginning of the end of the T wave. So this is called the ST segment. So if the ECG shows ST segment is elevated or depressed, both, this is the isoelectric baseline, right? So if it shows too much elevated or too much depressed, myocardial ischemia or injury may be indicated. This is the very important, it comes very fast here. This is the baseline, is getting too much elevated than normal. So this is the ST. So what is going to happen? S is going to come in the isolated baseline, right? And then is going to make the T wave. Am I right? As per rule, as per the normal ECG, what is going to happen? P baseline, QRS deflection baseline. After doing the baseline, then is going to make the T wave, right? Baseline.
Yes, right.
But right? Understand
Yes.
everybody?
Yes.
But if there is a problem, what is going to happen? It's not going to return to the baseline. It's going to be up or down. If it goes down and look like this tube, so this is called the ST elevation or ST depression. So if the, instead of going back after S wave, after the negative depression, it doesn't go to the normal isoelectric line or baseline, but it increase up the baseline. That means it's called the ST elevation. And this is a huge, one of the major indication or symptoms that patient may have some heart problem and maybe is going to have a acute myocardial infarction. That means the heart attack. Even the patient is not feeling anything like that. He came for a little bit chest pain, no discomfort, and the patient is not thinking even that I have going to have an attack. But from this, whenever we saw this type of ST elevation, immediately it has been transported to acute. Even the patient comes somewhere. So development of pathological Q waves on the tracing. Sometimes you can see a Q wave after T wave. But this area, ST elevation, this is for your practical, professional things and also for your taste and anything. ST elevation is one of the major indication for acute MI. How the ST segment normal? This is the isoelectric point. So see, this is the elevation. Begins with the end of the QRS complex, it's with the onset of the T wave. He's going to the baseline almost. See, this is the baseline, almost baseline. Negative deflection, okay? This is the J point, then slowly it's going to the baseline, and then it's forming the T wave. Going back to the isoelectric line. This is the ST. But if this baseline instead of, you can see that you cannot understand T wave properly because this is going to go up here from here. This is called the ST elevation. T wave normal produced by ventricular repolarization, you guys know now, or relaxation, commonly seen as the first upward positive duplication following the QRS complex. So this is QRS complex. This is called after upward positive, means this is Q is negative deflection, R is positive deflection, then S goes to the negative deflection, then it goes back to the isoelectric line. This is called the ST segment. This is the J point where S wave is meeting with the ST segment. So then ST segment then is going to form the T wave. So this is the again positive deflection. This is the normal T wave. Abnormal wave segments. The three steps are to determine if the patient is having ischemia, injury, or infraction patterns in the ECG. What are that? ST depression, that means when is going to the go down, ST elevation, and the formation of the Q wave, which comes after the T wave. And T wave depression or elevation in the same case, sometimes T wave. So abnormal wave. The T wave can also be altered due to myocardial injury or infarction. So where is the T wave? So you can see the negative. So this is QRS. What is this one? Positive deflection of the ST or negative?
It's negative, ma'am.
Negative. So this is the ST segment.
Yes.
Instead of going to the baseline.
Yeah. Instead of going up.
So it was supposed to, from here, is going to go negative direction, go to the baseline, right? And then after that, they are going to form a T wave. But here is the ST depression. Then you can see how much is the Q wave now. Then it is going like this. So these, if you see this one, there is obviously something wrong in the ventricle or your ventricular problem. So there is a patient can have some myocardial infarction. Okay. Again, also these are all showing the negative diffraction. Oh my God, see how this one is, instead of going to come here and go back, how the formation is there. V2, V5 lead. So that means we are so much acute, this one. And V2
might
lead.
be a possible myocardial infarction already, ma'am.
Yeah, you can see instead how much it going to the
That's
negative
very
deflection,
low.
the AS even, AS, it cannot come back. That means there is a problem in the ventricle cannot repolarize. It's contracted and stayed there. It cannot repolarize. So it's staying like this. And even there is no basically ST segment. Again, it's begin the T wave.
That's right.
Yeah.
I'm beginning to understand. Thank you.
Yeah, it's hard. We don't need that much, but I just like to show you that for your curiosity. You know how the ECG is important. So T wave should be upright in most lead, but it became lower. If it is inverted or negative deflection, then it's a sign of either injury or ischemia. When there is a negative or positive, both abnormal T wave or ST elevation or ST depression, there is a sign that there is maybe injury or ischemia. Okay. ST depression, that is the ST. They are showing this one, ST depression. This is the end of the QRX complex, okay? ST depression. ST depression occurs due to myocardial ischemia, as we discussed. Hypoxia results in altered repolarization. Hypoxia means when you are having less oxygen. If you are going in the altitude, high altitude, sometimes you can get this one. Sometimes who has the problem in the shortness of breath or who has the heart problem, they cannot go well in the high altitude and they doesn't allow to go. Especially also in the flight, they doesn't allow to, because as they have hypoxia, you have less oxygen, less blood flow, is going to give you more problem.
Yes, ma'am. I have a relative actually who had a heart attack in the plane.
Oh, see?
Yeah, that's true. Yes, ma'am. That's true.
Characterized by a deep below isoelectric line of 1 to 2 millimeters or 1 or 2 small boxes. If it is small boxes, this is the isoelectric line. If it is, this is the isoelectric line, right? It's going there. Only 2 boxes. Till is so important. right?
Yes.
So one box is, what is the length? One box? One small box? What is the length?
0.04 millimeter.
The length is
No.
one millimeter.
1 millimeter.
Length is millimeter and 0.4 is the
Length,
second.
okay.
It takes the
1
time to
millimeter.
travel. One small box is 0.04 second.
0 seconds.
And
Yeah,
the
okay.
length is in the millimeter. Okay, so
Yes.
length is 1 millimeter. So it travels, it going down to 2 boxes. That means how many millimeters?
2.
2
2
millimeters.
millimeter.
2 millimeters. And if instead of traveling 1, if it is travel more than here, how many seconds?
0.02.
How many
You
seconds?
said three. Three.
Is it 3 boxes?
Boxes.
Three
How many
Three
boxes.
boxes.
Uh,
3
point
boxes.
12.
I'm telling 3 boxes. 0.12.
0.12.
0.12.
So
Yeah.
you can understand how
0.12.
you can understand if there is a delay or how does the length. So 1 millimeter or 2 millimeter or 3 millimeter or 5 millimeter. So all the boxes are measurement like that. But even 1 or 2 boxes deviation is so sensitive. 1 or 2 boxes deviation, I just go up or down, can give you the sign that there is maybe probable heart problem ischemia to infraction. Is continuing ventricular, it can have the ventricular hypertrophy. That means ventricle cannot relax anymore. Ventricular conduction defects, that means the Purkinje fibers, which cannot contract and relax properly. Medication, digitalis, this is another medication. So this medication can also cause the ventricular problem. No irreversible injury due to the myocardium. That is a problem, infection or anything or damage in the myocardium, but it cannot be reversible. So it's always going to give you this type of symptoms. ST depression. ST elevation now. This is the transition mark. You can see baseline and then this is the baseline. It went up. A rise above the isoelectric line of 1 to 2 millimeters. Isoelectric line 1 to 2 millimeters. It can be more, but 1 to 2 millimeters is enough. Most common cause is myocardial injury. Everything is a myocardial. It's the myocardium. What is the myocardium? Which area of the heart is having the myocardium? Mostly
Ventricles.
ventricles. Those are the more powerful station, right?
Yes.
So if they have the injury, there is more problem. This can be seen in lead 2 in some types of myocardial infarction. So lead 2. So what are the other causes? Coronary artery vasospasm. It's called when is getting the, it's called the angina. It's the name is the Prince metals angina. When the coronary artery is having the spasm, it has the pain, coronary artery. If the plaque formation, if the hardening of the artery or it's not getting the proper blood flow, coronary artery by itself can make feeling pain. That's called the vasospasm. During the problem, vasospasm. Vaso is related to the vessel. Spasm means contraction and relaxation, which can lead to pain. Pericarditis. Pericarditis means, what is pericarditis means?
Infection in the pericardium.
Inflammation of the pericardium.
Pericardium. So if there is pericardium, it's going to affect all leads because its heart is covered by the pericardium, right? Ventricular aneurysm, early repolarization. So you don't have to remember all of these things if I am confident, but you have to remember what is the ST depression importance, why the ST elevation is important. It's the same thing like the myocardial hypoxia, you can guess the ST depression or the elevation. Tissue damage at the point is not repairable. The heart muscle you have on heart attack, but the tissue that is not, you survive, but the heart muscle has been damaged. So non-stop, you are going to have the S-type ST segment of elevation until ECRP. Pathology Q waves. Pathology Q waves indicate irreversible tissue damage or death of myocardial tissues when you see the Q wave. Defined as a width greater than or equal to the one small box or depth greater than 1/3 of the R wave. What is the Q? R. So it's 1/3 of the R wave. Sometimes it comes, it's called the Q wave. The EKG changes that occur at each stage of MI. So you can see the depression, right? After depression, what is happening is making irregular, then getting the EQ wave. Cardiac emergency. MLAOT should report immediately to the healthcare provider if any of the following symptoms are observed with the patient: breathing problem, loss of consciousness, cold sweat. If patient exhibit these symptoms and the ECG tracing is indicating an acute MI, do not let the patient leave the outpatient lab on their own. The patient came you in the outpatient lab, even not in the hospital, and you see any of these symptoms in the ECG. You are not allowing that. You have to tell the patient, don't scare them, but tell them, okay, have a seat. I have to talk to the doctor, and the doctor is coming to follow up with you or whatever. Because they may have a acute myocardial heart attack or infarction. What are the potential three, or I did tell me couple of potential symptoms arrhythmias?
Shortness of breath.
Yes.
Palpitations.
Yeah.
Yes.
Irregular heartbeat.
That is arrhythmia. Irregular heartbeat.
Heart rhythm. Yes.
Palpitation.
Fainting.
Downing, dizziness, shortness of breath, pounding in the chest. We already told, right?
Yeah.
Yes,
Anything, weakness, fatigue. So anything.
Just
If the
discomfort.
ECG shows T segment is elevated or depressed, myocardial ischemia or injury may be indicated, yes or no?
Yes.
Yes.
Okay. True. What does the following wave pattern demonstrate?
Bradycardia.
Arrhythmia.
Arrhythmia, because it's irregular, right? Yeah,
Irregular,
complex,
yeah.
complex arrhythmia. Very good, very good. Arrhythmia. It's a complex arrhythmia, but arrhythmia is good.
Yes.
Okay. Okay. What does the following wave pattern demonstrate?
Atrial fibrillation.
Good. Atrial fibrillation. Very good. Very good. I'm so happy.
Answer is there, Miss.
You are getting marks on. Everybody understand? Everybody understand? Again, I am hearing who are participating. I acknowledging them, not in by name or person. I can hear everyone's voice, understand. But who are silent, please participate. That's way you will be benefited, not me.
Yes, ma'am.
Yes,
When you
Miss.
speak,
Yes,
it goes to your brain. If you speak, it hits your brain. Not only listening or watching, okay? So this one is done. Let us see what is the next one for us. You have to do that one also. Arrhythmia flashcard.
Yeah. It's a problem with the read.
That you can do. What is the answer? Rhythm of the heartbeat.
It's quite blurry, ma'am.
And
Larry?
problem with the rhythm of the heart. Rhythm of the heart. Arrhythmia. Rhythm of the heart.
Sure.
Myo,
No,
it's
yeah,
arrhythmia.
arrhythmia.
Okay,
Arrhythmia or dysarrhythmia.
out of 19, how many? Just raise your hand. How many you agree is arrhythmia, and how many not? Raise your hand. How many agree is arrhythmia? Raise your hand in the computer. Nobody?
No, we did, ma'am.
Oh, I cannot see. Okay. Alexia, Asne, Keys, everyone like this. Who is the Santiago? You doesn't think it? What do you think, Santiago? What about Sabana? Yes.
Ma'am. I already raised
Okay.
my hand.
All are okay. So who is else? The next one. I didn't see the hand. Raise your hand. Keep your hand raised, dear. Okay. Joanna, what do you think? You also think it's arrhythmia?
You raise your hand, miss.
My hand, I
Yes,
cannot
mom.
raise. I cannot raise my hand.
No, I said
Dugato, what is your Dugato? What do you think? Yes. If we fail, what is going to happen?
Then 19 of us are wrong.
Huda? Right. Okay.
Yes, I agree.
Yes.
Okay. Good. Arrhythmia or dysarrhythmia? Dysarrhythmia is the painful arrhythmia. So that's the dysarrhythmia. You guys know what are the possible symptoms of arrhythmia, right? Just we discussed, right? Yes.
Pounding in the chest.
Yes.
Dizziness.
Discomfort.
Yes.
Shortness of breath.
Fainting. Yeah. All of them. Okay. Okay. So you guys know that. Pounding the chest, dizziness, shortness of breath, chest discomfort, weakness or fatigue, everything, palpitation for sure. What is the next? Increased rhythm more than 100 beats per minute is called?
Tachycardia.
Tachycardia.
Everybody knows that answer at least. Okay, good. Arrhythmias that begin in the atria is called?
Supraventricular arrhythmias.
Tachycardia.
Tachycardia.
No, that is the defined
Supraventricular.
arrhythmia. Yeah.
Supraventricular arrhythmia.
Supraventricular arrhythmias, and which begins in the ventricle is called the ventricular arrhythmia. Okay. And when there is a problem in the conduction system, delay is called the, that is, I always define bradyarrhythmia. What is bradyarrhythmia?
It is slow heart rhythm.
Slow heart rhythms that may cause disease.
For due to
Sinoterial.
Due to
like Parkinson.
Disease in heart conduction.
Heart conduction system. Yes,
Yes.
exactly.
Yes.
Yeah. Slow heart rhythms may be caused due to the disease in the heart's conduction system. It can be anyone, SA, AV, Parkinson, anyone. But it's anywhere in the total heart conduction system. Identify 4 possible causes of arrhythmia. You just did. Just tell me 4.
Heart disease.
Injury from heart attack. Injury from heart
high blood
attack.
pressure.
Electrolyte imbalance.
High blood pressure.
Yeah.
I have an injury from a heart attack and high blood pressure.
Electrolyte imbalance. That is one of the major one. Electrolyte imbalance, sodium and potassium.
Sodium and potassium.
Healing process after the injury. So, okay?
Okay.
Okay. A TOF which is inverted or a negative deflection is a sign of what?
Injury
or ischemia.
Injury and ischemia.
Good. You guys have the answers there already? You guys are doing so good. Okay. ST segment depression can occur due to?
Myocardial ischemia.
Myocardial. Yeah.
Yes. And which can leads to myocardial?
Infarction.
Infarction. Very good. ST segment elevation is characterized by the rise above the isoelectric line. How many millimeter or boxes would be approximately be?
1 to 2 millimeters.
1 to 2
1
millimeters.
to 2 millimeters.
Yes.
Pathologic QFs can indicate?
Tissue damage.
Tissue damage. Non-reversible, irreversible, not only the tissue damage, it's irreversible, which cannot be reversed again. Irreversible tissue damage, mainly the heart. Okay, good. So what is the next? You have to do that one, that part, okay? So I'm going to leave now. ECG, PowerPoint. You need
Which one we have
8.
to do?
We have more?
This review PowerPoint.
No, that's
Oh
just
my
a
God.
review. No, it's a
It's
review.
just a review, ma'am.
Yeah.
Oh, that's a review. Okay.
Already checked it.
Oh, you already did it. Okay.
Review activities.
I am doing non-stop. I am doing a non-stop. I am doing the review. So you guys are, yeah.
Yeah.
Mom, we still have the activity that you have said that we're
Yeah,
going
you
to
have to do that
answer.
one. To that
Yeah.
one. Okay. So tomorrow.
Mom, we lost you.
What is this?
We lost you, miss.
Yes, ma'am. So basically, one thing, just let me tell you these things and then I can tell you the vital signs. I'm not going to teach you tomorrow. Okay, so tomorrow you guys do the review. Though it is still optional, but you have to do it in the lab, right? So we are going to go through it. What is the vital signs means? Okay, we are going to go to the vital sign PowerPoint, different types of quiz regarding the what are the different types of body temperature, pulse, respiration, because you have to do it in the lab. Okay, so I'm going to go it not tomorrow. If you want, I can go it tomorrow, but I think if you need time tomorrow to do your reviews for your ECG final, so then I'm going to do it Thursday. Okay.
This Thursday.
What?
This Thursday?
I'm going to talk to Bheda till now. I didn't get time. Talk to Bheda when we are going to do the exam. If we have the exam on Wednesday, then we are going to do the vitals on Thursday. If in case we have to do the exam on Thursday, then I'm going to teach you these vitals tomorrow, and then you can go for your preparation. Okay. And by this time, I already send you the final review questions and also the 900 ml per questions with answers.
Thank you, ma'am.
And this will be in the lab, right, ma'am? We have to come to the lab to do it?
I think so. Yes, the final one. So by this time you have couple of minutes, please complete that one. So then you are going to be done, okay?
Yes, miss.
That the drag and drop or something like that, what you had before.
Yes, ma'am.
Yeah, yes, mom, we did
Different
already.
types of
I did.
arrhythmias of kind of like that. You already did it? Okay,
yes,
good
Yes,
girl.
mom.
Good girl.
Ma'am,
So
I have a question.
who has a question?
Me, Shabana.
Yes.
So if this Wednesday we come in for ECG to take the exam, do we continue in lab after that? Or do we go home and then continue our session?
No. If you come to the lab, then we are going to continue there. We can do a couple of hematology reviews in the lab.
Okay. So we stay back in the
Oh,
campus,
I am
right?
going to tell you. I am going to tell you one thing. 29th and 30. Probably you are supposed to be on online. Check your calendar. 29th and 30th April. In as per our calendar, we are supposed to be online. But that 2 days, I request you guys to go on the campus, work with Sabana on the lab, because I'm telling you that week we are starting the Monday and Tuesday. I have somebody coming from the India. I already talked with them. So it is starting the quality assurance and math. Okay. So if you guys go to the campus and do the lab work, in exchange in the next week when you are going to the lab, I am going to continue the Q and math. Okay. So I feel that it's comfortable to go from the theory portion, from the quality assurance math with only one instructor. It my feelings, but if you think you can go with Sahina has no problem, I have no problem. If you think you want to do stay online and start with Sahina 29th and 30th, then I can join from first, that is fine. But if you think you guys can go on the campus for those 2 days for the practicals, and then from Wednesday to next Tuesday, I can do the online.
Okay, ma'am.
Is that okay for everyone?
Yes, ma'am.
Yes, ma'am. That's fine.
Thank you. So suddenly,
So we're just going on campus the 29th to the 30th just for the maths.
No, not for the maths. That
No,
time
the
you
not for the
laboratory.
do
maths.
the
She's
lab
saying just
things.
to do
That time
lab,
you do
and
the
then
lab
when
things.
when
And
she
those 2
starts on
days
the
for the
first
Q and math, I'll start from the Wednesday to
Wednesday.
following Tuesday.
Okay.
Sounds good, ma'am. Thank you.
Yeah, ma'am,
Because
that's
Q
fine.
and math is
It's
little
okay.
bit tricky and other things. It takes
Yeah.
time. And also in between, even if you go there, I'll tell Saina, even not that, I will tell Saina if she can start little bit making the solution, very minor things, right? How to do that. So I will give you the sheets, and then if you can do this little bit, start it. So then I am going to go to the more complicated things in the quality assurance and math.
Okay, ma'am. Sure.
Okay, Zenaida, you have some question?
No, ma'am.
Your hand is raised, so I thought maybe.
Oh, sorry.
It's okay. It's okay. It's okay. It's okay. Thank you. Thank you. Savannah, I forget to send you the message. Your biryani is very good. We enjoyed a lot. Thank you very much. And my daughter
my
loved it.
pleasure.
My daughter is a biryani,
Lover.
lover. Yeah. She liked it. Thank you. I was thinking so many times I'm going to send message, and so many things are happening, and my
No, it's my
knee.
pleasure. I'm happy all of you guys enjoyed it, miss.
Yeah, thank you. Even your how is son?
He's good. He's got better now. He finally went to school today, so I could drop him. That's why it's quiet in my house now.
Okay, so you guys who didn't complete that one, please complete, and then you guys are free to go. Tomorrow you can practice. We'll decide if the after this I'm going to talk to Vera and other things when the exam is going to be due. So if it is on Thursday, we are going to complete the vitals, and if it is not, then you are going to. If it's on Wednesday, you guys are going to do the review tomorrow, appear on the exam on the Wednesday. You have to take the exam either if you take the in the past up, then you are going to go to the vitals after that because you have to be online or somehow. We'll see how it works.
Okay.
Okay?
Yes.
Okay. Thank you very much for
Yes,
listening
ma'am.
as
Thank you.
usual.
Thank you,
Thank you,
ma'am. Thank you
miss.
for helping us
Making you
out.
bored,
Thank you,
asking
miss.
you too many
No,
questions,
not at all.
and also send a review if you can, whatever Rajiv wants. Okay, if you can.
Sure,
That
Yes,
is
of
not
course,
ma'am.
ma'am. We'll
mandatory.
do that.
Okay.
Yes.
Okay.
Thank
Thank you.
you.
Thank you.
Thank
Thank you,
you.
ma'am. See you tomorrow,
Okay.
guys.
See you
See you
tomorrow.
See you
tomorrow.
Yeah.
tomorrow.
Bye.
Tomorrow you start your review. You are like in the group or tonight you try to do as much as possible because there will be lot of common questions is going to be repeat from the test one because you see test two how many there will be not too many questions. That's the majority questions is going to come from the test one.
That's one.
Maybe couple of arrhythmia this type of maybe questions maybe one or two come from there. The different types of dexocardia or this type of otherwise mostly major we did in
Yes.
the test one.
It's
So
all in test one.
yeah, majority of the
Is it
questions
going to be around the same time as test one, like the time limit we were given, or is it going to be a little bit more? Because
it depends upon how many questions. Generally finals are always more questions, but I didn't check that one. So it's going to be 1 hour or 90 minutes or something that
so
I
the whole of ECG, we just had to study your further reviews that you gave us, and then whatever we studied today,
Final,
right?
yeah. ECG test one to test two. I'm telling test two, you are going to say same answers. Try to answer it without looking at your first review. So that like that you are just giving the exams, right?
Yes, ma'am.
Whatever you did mistake, then you go or ask me. We can discuss. Okay.
Yes,
But
ma'am.
first go with yeah. Okay. Thank you. Okay.
Thank you.
Okay. Bye bye.
Yes, ma'am.
Bye.
Thank
Bye,
you.
Thank
everyone.
you.
Thank you,
Bye.
miss.
Bye.
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 Everyone.
Bye.
Bye, everyone.
Bye.